Hi everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Taylor Hayes, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the December 2024 issue dedicated to Odontogenic Sinusitis, guest edited by Drs. John Craig and Alberto Saibeni. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. And today I am speaking with Drs. John Craig and Alberto Saibene, the guest editors of the December 2024 issue of Clinics, which is on odontogenic sinusitis. Dr. Craig is division head, rhinology, and clinical professor in the Department of Otolaryngology Head and Neck Surgery at Henry Ford Health, Michigan State University College of Human Medicine in Detroit, Michigan in the United States. Alberto Maria Saibene is associate professor in the otolaryngology unit of Santi Paolo e Carlo Hospital in the Department of Health Sciences in the Università degli Studi di Milano, the University of Milan in Milan, Italy. John and Alberto, welcome.
Thank you, Sujana.
So thank you both for making the time to record this podcast. Between us and our liaisons at Elsevier, we've spanned all the time zones in the United States and in Italy as we record this. You've put together a really educational and enjoyable issue on odontogenic sinusitis. This is a challenging subject as it spans otolaryngology, dentistry, maxillofacial surgery, as well as infectious disease and radiology. And as is often the case, when more than one specialty is involved, patients and their concerns often fall between the cracks. When we discussed what you'd like this issue to look like, I think you made the safety nets between specialties a highlight. So I think you kept this really patient-centric so that the patient can approach any one of those types of physicians and healthcare providers and not get lost between providers. In this issue, you've put together 17 articles that cover the subject of odontogenic sinusitis in detail. You've divided the issue into 3 sections. Section 1 is on epidemiology, anatomy, and physiology. Section 2 is on multidisciplinary approach for diagnosing odontogenic sinusitis, which I think we will end up referring to often during this podcast as ODS. And Section 3 is on managing ODS. I strongly encourage either online at www.odo.theclinics.com or in their institutional or personal libraries. It is a thorough resource and can easily be picked up again and again and be very helpful as you see patients in the clinic. For this podcast, Drs. Craig and Saibene and I will discuss some important concepts for all healthcare providers involved in the assessment and management of people who present with odontogenic sinusitis. So let's get underway. My first question is going to be to Dr. Craig. John, let's start at the beginning. What is ODS? You and Alberto study it intensely, but how does the average otolaryngologist ensure that they both don't miss the diagnosis and don't overdiagnose it?
So let's start with the first question. What is it? We've tried to be consistent with the definition across consensus papers and throughout this book. And it can be as simple as saying we're talking about infectious maxillary sinusitis, bacterial infectious sinusitis. We're not talking about fungal conditions right now. Can involve the other paranasal sinuses to varying degrees. And these stem from infectious maxillary dental pathology, or they can follow surgical complications from dental procedures. I think that's a good way to think about it. It's a mouthful, but it really does cover the numerous etiologies that can cause this. And I think it's huge for medical providers to know that it's not just an infected tooth. There's actually a number of different dental conditions that can cause it. And we did a pretty thorough job outlining all the different causes in this issue. Anything else you would add to the definition there, Alberto?
The definition is just perfect. As you said, it was difficult to come up with something that covered like an umbrella term, but at least specific enough to avoid overdiagnosing, as it was a huge gap in the previous literature. I mean, previous that what we did in our consensus, since odontogenic sinusitis was used as a term stretching over several condition, starting from simple mucosal thickening of the maxillary sinus to full-blown complicated ODS. So we tried to tidy up things.
Yeah.
I think you did. And I think when you separated out the issue into those three sections, it really gives somebody a chance to kind of really absorb what it is before thinking about how to diagnose it, before thinking about how to treat it. And I think that's really logical. I know you've included some really nice articles thinking about somebody presents with unilateral maxillary sinus thickening or opacification. When do you diagnose ODS? When do you want to not diagnose that as ODS?
So I'll take this first because we're going to hit on this numerous times throughout this podcast because we've talked about this a lot. It might be one of the most important problems between the dental and ENT literature. And I'm not singling out one or the other because both of our fields have been guilty of this. Maxillary sinus mucosal thickening, what we're talking about is on a CT scan, seeing thickening, gray line thickening, whatever you want to call it, adjacent to underlying maxillary dental conditions, prior dental work, anything, but also in the general population. It's well known. I mean, we could cite 10 studies that show anywhere from 18 to 45. Some studies have shown like 60, 80%. Like mucosal thickening is very common in people without any sinus or dental disease. But add to that, in the dental literature, there's definitely 5 papers, and that means there's probably more, that show anywhere from 45 to 100% of people with dental conditions or dental pathology are going to have maxillary sinus mucosal thickening. What's missing from the literature, the nasal endoscopic findings in those patients. And so people who manage a lot of these patients, we know that if somebody has mucosal thickening alone, it's rarely, extremely rarely going to have, the patient's going to rarely have endoscopic findings of pus or edema in their middle meatus or maxillary sinus. And so what we're trying to do over time is we can't keep calling them the same thing. We presented a lot of dental meetings and they'll show their results of dental treatment. And I'm not, again, dental listeners out there, this is not calling you out. It's just we have to keep sharing our knowledge. The point here is if you treat a tooth that has maxillary sinus mucosal thickening next to it, there's plenty of studies showing that mucosal thickening improves. That is not the same as saying odontogenic sinusitis resolves. And so, again, I didn't do a perfect job right there of distinguishing the two. We're going to do it at least 10 more times in this talk. But I think the key distinguishing point there is the pus. Okay, so when we look in the nose, we're looking for a purulent sinusitis. That's the definition of the condition. And so that's what we want to see. If somebody has mucosal thickening, it does happen sometimes. You'll scope them and they will have a purulent infection. It's just really rare. Does that make sense?
Yeah, I think that's really a very key point. One of the things that I liked a lot about this issue, and I liked everything about this issue, is that you included some really cool, I happen to be an anatomy nerd, so you included some really cool articles. There's a great discussion on maxillary dental anatomy and physiology, which, you know, in medical school, we just skim over. Like we very vaguely know that there's some teeth underneath the maxillary sinuses, right? That's basically all we know about them. And we know what happens when you break your jaw and you have to align those teeth, and that's about it. But I think giving the otolaryngologists a beautiful primer on maxillary dental anatomy physiology with fantastic images in the article by Ordinola, Zapata, Acevedo, Tatarian, and Versiani. And then for both otolaryngologists and dentists, a really nice revisit of maxillary sinus itself, anatomy and physiology by Mularsik and Welsh. And that includes, they have a really nice table in there looking at the vertical and horizontal relationships between the floor of the maxillary sinus and the maxillary dentition. So I will urge our listeners to go back and look at that, because it definitely opens your eyes as to what Doctors Craig and Saibene are referring to as adjacent, maybe some thickening versus adjacent odontogenic sinusitis. So Alberto, as we move along, I know that we can further subdivide ODS or odontogenic sinusitis into uncomplicated and complicated. So can you tell us the difference between these and how common is each of those?
Thank you for the question. This is, I have to admit, this is one of John's great ideas, to subdivide ODS into something that is pretty useful to classify. So if we look at uncomplicated ODS, we are talking just the sinusitis, which might bear huge symptoms for the patient, but there's no osseous, eye or orbital or brain involvement. So everything that comes out of the sinus becomes complicated sinusitis, complicated ODS in this case. As long as we think about the epidemiology of ODS and the subtypes of ODS, we are somehow hampered by the fact that there are not so many studies using standard definition criteria for getting what is really ODS and what is just an odontogenic infection with some kind of mucosal thickening. So if we stick to what we know, we can expect ODS as being the most common cause of operative extrasinus complication, going up to 58% of complicated bacterial maxillary sinusitis when we exclude fungal causes, of course. Extrasinus spread of odontogenic sinusitis, so complicated odontogenic sinusitis, mean that we are looking at orbital, intracranial, and osseous complication. Complication involving the orbit, just like for rhinosinusitis, include preseptal cellulitis or abscess, orbital cellulitis or orbital abscess, subperiosteal abscess, and cavernous sinus thrombosis as a further anatomical and functional complication. Intracranial spread of infection can lead to meningitis and abscesses in the epidural, subdural, and intraparenchymal compartments, while osseous complication, which may be the least simple to identify, refer to sinus wall osteomyelitis, which can further progress to subperiosteal abscess, and also in rare cases to sinocutaneous fistula and orbital or intracranial spread as a further advancement. There's a small side note on this epidemiology, which stems from a recent systematic review we did, that shows that this kind of extrasinus complication have been reported as disproportionately more frequent in the pediatric population of ODS when comparing to an adult patient. But we don't know exactly if there's some kind of niche pathophysiology for pediatric patients with ODS, or there's just a huge publication bias, since this literature is made up most often by isolated case report that we know tend to focus on more extreme complication. If we look at the pathophysiology of ODS as shown in the awesome article of the OCNA issue that Professor Craig and Professor Hopkins wrote together, we can just look at how different the pathophysiology of ODS can be and how this disease progresses from simple dental infection. There's a wonderful image in the OCNA issue that allows us to see over the course of several years how a simple maxillary molar infection goes into full-blown ODS over the course of years. And these radiological changes mimic somehow what happens at a cellular level when ODS develops. We have to take into account that histological ODS mucosa is characterized by a normal pseudostratified columnar epithelium overlying some kind of severe subepithelial inflammation with a type 1 lymphocytic infiltrating the lamina propria. But ODS inflammatory cell population have been studied very heterogeneously across studies. And there's a variable mixture of eosinophils and neutrophils present among lymphocytic cells. So there are intriguing specific findings in regard to mucosal inflammation in ODS that we noticed. First, multiple studies have shown that patients with ODS have papillary mucosal edema, both histologically and macroscopically. And theoretically, this papillary protrusion could be some kind of adaptive response to increase mucosal surface area to enhance the mucociliary clearance. So somehow the maxillary sinus feels that there's something wrong and tries to clear out this infection and inflammatory material and deliver a better antimicrobial factor. There's a study from Zhang and colleagues that compare ODS, CRS, and some control patient. And in ODS patient, there's overexpression of tight junction protein called Claudin-4 that reinforces the idea that ODS tries, in ODS, the maxillary sinus try to maintain an intact mucosal barrier with enhanced tight junction impermeability. So it's like the maxillary sinus try to hold everything together and actively fight off the underlying and overlying sinus infection. But sometimes this infectious process comes out of the sinus and tend to develop an extrasinus complication. So as a general rule, the pathophysiology of the extrasinus complication is rather straightforward. There's some kind of thrombophlebitis through the diploic vein that traverses the bony foramens and canals. So there's a direct extension through body sinus wall into the orbital or intracranial spaces.
The extracranial complications seem to be somewhat similar
Exactly.
across sinusitis, but
Exactly.
very interesting, the cellular structure differential in the maxillary sinus in response to inflammation just in its basement, I think is what I'm hearing. And John, did you have any other points to add to that?
I think what's really important is we don't know truly how common uncomplicated odontogenic sinusitis is. He gave an excellent dissertation there about the extrasinus complications, and he alluded to a paper that we published here at Forward with University of Pennsylvania. Nearly 2/3 of the patients that you're going to take to the OR emergently or urgently for extrasinus complications will have an odontogenic source when you rule out tumors and fungus. So
wait, say that again, John. Just say that statement again, because I think that's really important.
It's huge. It's huge. I mean, so anyone who operates on extrasinus complications, these are hectic situations. You get a phone call at 10 p.m., residents say, we got to board this patient, patient's going blind, whatever. Everyone's so focused on the blindness and the sinus, nobody scrolled through and just looked down at the teeth. And so that was the impetus behind the study. And so if you just separated out the invasive fungals and the cancers that you take to the OR emergently, 2/3 of those cases were odontogenic sinusitis. I mean, it's wild when you think of how common that is. Now, taking a step back, it's still very uncommon on the whole. So if you just look at the literature, we're talking in the order of like 6 or 7% of all published ODS cases are extrasinus complications. Okay, so it's not like most ODS spreads to the eye or brain, but I think the important point is it's a very common cause if it does get to that point. That image he talked about in our pathophysiology chapter, that was just one example. There's another wild example that I present sometimes, similar situation, and this gets back to mucosal thickening. We're kind of poo-pooing it that, okay, it's not ODS. But the thing is, it is still an indicator of underlying dental disease that can then turn into ODS. And then a horror story, my patient, 10 years later, subdural empyema, and required, and unfortunately the patient passed away 2 months later from cerebrovascular complications. So point is here, like ODS is a common cause of bad problems. It just doesn't usually get to that point as long as you treat it. And that's we're going to get into management. It's not hard to treat this condition. You just have to recognize it.
Alberto?
I just want to add another layer of complication for complicated ODS. We have to take into account that we have lots of reports of extrasinus complication arising from isolated dental pathology without any sinusitis. So the sinuses do not necessarily serve as the avenue for spread. There are independent routes of spread that are important to consider. So if we are looking, I don't know, as John said, subdural empyema, but we don't have sinusitis, maybe just look
at the teeth. Yeah, great point.
So, as we continue this sort of thought, we talked about you guys in your book, in your issue of Clinics, talked about the different causes of odontogenic sinusitis. I had a few questions for you guys. I know that you presented a really amazing article on pulpal and periapical pathologies in the article on endodontic infections by Silva, Pinto, Versiani, and Sassone, and then periodontitis by Tonetti shows a lot of systemic comorbidities associated with this issue. And I have to tell you, having read the articles in this issue, I am a much better flosser than I ever was because, oh my God, I really like you guys and I don't want you to ever operate on me. But can you talk to us about the causes? Are they the actual dental pathologies? Are they different in the US, in Europe, in the developing world? Like, where does this go for us? How do we maintain our index of suspicion?
Dr. Tonetti's article is great because it at least teaches us what periodontitis even is. The first part of your thing was like basically there are a number of different dental causes. So just talking to colleagues around the world, I think it's pretty common, the spread of different dental etiologies causing ODS. One of the factors there is that different countries have different levels of dental subspecialists. So like some countries don't have endodontists, for instance. So you might not pick up as much endodontic pathology there, and it might just be called, I don't know, dental abscess, or they might call it periodontitis, which brings me to I'm just going to talk endodontic right now, because I think if more ENT surgeons knew the different spectrums of endodontic disease, we'd be a better field. Okay. I never learned about pulpal disease or something called apical periodontitis in all of my training. And I give a big shout out to Rod Tatarin in Spokane, Washington. Awesome guy. He's been studying ODS on his own as an endodontist with a general ENT colleague in his area for like way before we started studying it. And then Alberto and I linked up, and then we reached out to him. And so that's why he's on a number of these chapters in this book. But I've learned a lot from him in addition to reading their literature. So here's what we're talking about. We're talking about pulpal infection, okay, in the setting of ODS, by the way. So there's different, you'll read in the book, there's different levels of inflammation that can affect the pulp chamber, usually in the setting of deep caries. So you get a hole at the coronal surface of the tooth, goes through the dentin, gets to the pulp chamber. Then you get an inflammatory reaction there. Eventually, the blood supply dies, becomes necrotic. Okay, so pulp necrosis then leads to pulpal infection, periapical inflammation and infection that then spreads to the tooth. And so, at least in my practice, we published a prospective study on this. It might be the only one still out there prospectively. 2/3 of ODS presenting to me, at least, were endodontic. Okay, and those were usually the classic picture that you see on a CT scan. There's probably like 80 figures in the OCNA issue of this. A little round periapical lucency at the apex of the tooth, maybe some bone erosion over that, and then you get the adjacent sinus inflammation or infection. And so endodontic causes, very common. I don't know about Alberto. Is it the most common cause in your practice, or is yours more oral surgical? But
in our practice, let's just say we don't have the right numbers. Again, it's an epidemiological issue, so we don't have the exact numbers. So I perfectly agree with John that somehow causes will be classified differently according to the different level of experience the otolaryngological group has, or the specific dental practitioner you turn to when you are examining your patient has. So for years, for example, in our practice, we just haven't divided endodontal disease and periodontal disease, and we just kept calling them classic odontogenic complication, because we didn't have, I lacked first the skill. I'm learning new things. As John said, when you liaison with other colleagues, you learn something different. So you get to know what is endodontic disease. You get to know something about periodontal disease. So there's this kind of inflammation and infection that goes somehow around the tooth and then reaches the maxillary sinus and the apex of the tooth by going all around the tooth, the periodontal ligament, and goes all the way up. And then you get to know all the different stuff that dentists do to allow prosthetic rehabilitation of the patient. So we are talking about the two big classes of oral surgery complication, which are namely those related to implants and those that we relate to maxillary sinus augmentation. So just to keep things the most simple, if you have enough residual vertical height of the bone when you need to replace the teeth a patient has lost for any cause, you can just simply put there some kind of implants. So we all know they are just this kind of little titanium screws that goes into the bone and allow prosthetic rehabilitation of the dentition of the patient. Maxillary sinus augmentation related procedures, we have to take into account that maxillary sinus augmentation require placing a little bone graft inside the sinus to allow some bone regeneration, to allow the further positioning of dental implants. So this bone graft you put inside a maxillary sinus, which can be autologous or heterologous, so it can be human bone or some kind of osseous substitute, can get infected and lead to complication. We have like 10% of all complications seen at my institution that come from maxillary sinus augmentation, 20% from dental implant positioning, and the remainder, so 70%, comes from endodontic, periodontic disease, extraction, extended caries with pulpitis. I know that John is very keen on this. Simple caries cannot lead to ODS, but extensive caries process that can lead to endodontic disease and apical disease. So if you just ignore your caries for too long, it can lead to ODS, but these are extreme cases. And we can expect, but we don't have exact figures, the rate of this classic dental complication skews in population who have worse access to dental care. And this population might have been historically less studied from an ODS point of view.
One thing, I don't know if we're going to get into dental diagnostic processes, but this seems like a good time to do it. We can talk about these conditions all we want. It's great that we have labels for them. It's great that we're aware, but how do you actually get it diagnosed? And this is not straightforward. So it is, in my opinion, not enough for us ENTs to look at a CT scan, see a suspicious area on the periapical region and say, that's an endodontic cause, okay? It's not that straightforward sometimes. And this is something we need to tease out with better research as time goes on. What is the predictive value of a CT scan compared to the eventual endodontic testing? So I think we should hit on, so that all ENTs know what proper endodontic testing is. It's not done by most general dentists, at least in the United States, not routinely. So what we're talking about is pulp vitality testing. I'm talking endodontic disease right now. That means cold, hot, or electric stimuli applied to these teeth that are in suspicion of being odontogenic sinusitis sources. You have to compare the normal side to the disease side, and then you're looking for response. If you apply a cold stimulus to most people's teeth, they jump, or they're like, whoa, that didn't feel good. These necrotic teeth are insensate. So it's a lack of response to the stimulus that you're looking for. That implies a necrotic tooth, and then you need to get periapical imaging, okay? And the ideal form is cone beam CT scan, but not all dental practices have that. And so if they don't, at least a periapical x-ray or a Panorex x-ray, those don't have as good resolution, and it's kind of wild when you compare. The more I look at them, you're missing apical disease frequently with them. And so the point there is pulp diagnosis, periapical diagnosis. That's how you actually get to the endodontic diagnosis.
So that's really very helpful because I didn't even know that such a way to test existed. So
Yeah.
that's really very helpful. And that's something that I think we can, us listeners to this podcast, can take back to our colleagues and say, hey, can you ask your dentist, can they do this, right? Can they do this sort of testing to make it clearer what the origin is? We've discussed some of the sinusitis pathophysiology, and I think you've included some beautiful images in the articles by Almali and Wang and by Kwiatkowska and you, John Craig, regarding the pictures of the teeth, the pathophysiology, the complications. You talked about how the appropriate dental workup can distinguish properly whether there's pulp disease or not. Alberto, what is the correct imaging when you suspect that this is odontogenic sinusitis? A lot of people will just get a CT paranasal sinus, and as both of you pointed out, we often ignore the tooth part of the imaging. So what's the correct imaging? What's the efficient imaging? Is there a role for plain films anymore?
This, I think, all boils down to our ODS mantra that we repeat so often. So diagnosing ODS requires otolaryngologists to confirm the infectious sinusitis and the dental specialist to confirm infectious maxillary dental pathology, ipsilateral at least, to the sinusitis. So for people working on ODS, specialists working on ODS and imaging, it's like the title of a well-known video game, It Takes Two to diagnose ODS. So if we look at the imaging, for what concerns the sinus, plain films have no role, so you just don't have to ask for a sinus X-ray in 2025. And we usually employ normal CT scans to identify all the affected sinuses and to rule out the complication if required. But if we put ourselves in the dentist's shoes, which I expecting as it comes to shoes, they are fashionable and comfortable, things get different. And of course, it's more difficult for otolaryngologists and rhinologists alike. So first and foremost, plain films, as John hinted to, have a role for analyzing dental focuses. So my personal suggestion is to encourage any otolaryngologist who has a little bit of interest in ODS to get used to look at orthopantomograph and apical radiographies. Even though CT scans and cone beam CT scans, which are becoming more and more available in dental practices, convey similar information, are easier for otolaryngologists to interpret, and might as well have really better sensibility and specificity. And when we look at the scans from a dental point of view, we have to analyze that there are different anatomical relationships between the teeth and the sinus, as we said at the beginning of this podcast. And the alveolar cortical bone usually separates the dentition from the sinus mucosa and can have variable thickness based on the extent of sinus pneumatization, age, and presence or absence of dentition, and of course also prior infections. This alveolar bone contains marrow spaces, and inside them the vascular elements that transmit the infection to and from the dentition via the apical foramina of the teeth. So as a general rule, there's this classification, which is also reported in the OCNA issue in the article by Dr. Mularczyk and Welch, that goes from grade 0, in which the root of the teeth is not in any contact with the cortical borders of the maxillary sinus, and goes all the way to 4, which is superiorly curving sinus floor, which envelopes part or all the roots of a tooth. Of course, this can be very easy to identify in CT scans of patient, and if we see the root of the tooth going all the way inside the maxillary sinus, we can have a huge suspicion, or at least we have to be very careful to rule out a sinus infection as a point of origin of our sinusitic process. Then, if we start from this rather straightforward analysis, there's a lot that we have to take into account. We are used to review a lot of imaging for ODS, and there's a lot of details that count. We included, of course, an article about imaging on ODS in our issue, which these two awesome colleagues that are Dr. Boydinghouse and Dr. Ratcliffe wrote for us, that shows that each and every modality, so starting from periapical radiographs, then plain films, so orthopantomograph, and then CT scans, allow us to identify different components of the ODS pathophysiology. So starting from, let's say, in apical radiographs that allow us to decide whether or not an endodontic sorry, an endodontic treatment has been successful or is just partial, that tells a lot about what is going on in an endodontic disease of a specific teeth. Then we have plain radiographs that allows us to easily identify bone resorption, and then we go all the way to CT scans that allows us to perfectly reconstruct the sinus and understand what's the true relationship of the tooth itself, its roots, and what's happening inside the sinus. Of course, there are also other modalities of imaging, such as magnetic resonance imaging and PET-CT scans, that might, in extreme cases, allow us some insight in ODS. They are not our imaging of choice, of course, but they might allow incidental diagnosis of ODS by showing either inflammatory signs at the dental or sinus level. So we shouldn't ignore MRIs or PET scans of patients.
So, you know, pictures in radiology are worth 1,000 words. And I think the 3 articles that you guys included really have extraordinary pictures. There's one that's side by side of odontogenic sinusitis on one side and chronic rhinosinusitis on the other. And that's in that article by the 2 of you and Dr. Safadi. I think there's some really neat images there that really make you think. And of course, you know, at least American medicine is all about Osler. The patient will tell you the problem if you actually ask them the right questions and give them a chance to tell you their story. So the simpler targeted history taking of, do you have dental pain? Have you been to a dentist? Have you had treatment of your teeth at the maxillary sinus level? You know, these are so obvious, and yet as we rush to, as John, you were saying, you know, oh God, this guy's got a complication and this guy's got preseptal cellulitis, you know, stop for a second and say, hey, could this possibly be dental origin? Because I tell my patients all the time, I went into medicine because I loved Sherlock Holmes and I wanted to be a detective. And I think these kind of cases give us the opportunity to be a detective and to really try to help the underlying cause. So we're not just chasing the tip of an iceberg.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Sujana Chandrasekhar. I'm speaking with Dr. John Craig of Detroit, United States of America, and Dr. Alberto Saibene of Milan, Italy. And we are talking about odontogenic sinusitis, which is the December 2024 issue of Otolaryngologic Clinics of North America. There's a lot of material in this issue, and I hope that you, our listeners, can access it via online or in hardcover. I love my hardcover copy because I love leafing through and kind of taking my time to go through things. And certainly if there's any comments you wish to make, please get back to us, because we always are striving to make our issues better and our podcast better. So let's focus on treatment. So John, Dr. Craig, you have a patient now who presents with uncomplicated odontogenic sinusitis and treatable dental pathology. So what comes first?
A lot of people want to focus in on, okay, it's ODS, it's obvious. We're going to treat the tooth, treat the sinus, one before the other, who cares? Okay, but people overlook the fact that they're missing it still. Okay, so a lot of ENT surgeons are missing this condition. And so what we've been doing with some of our prospective studies over the last 5 years is keying in on certain clinical features that should tip you off and say, oh, maybe I should look down at the teeth. We would love to get to a place where everyone is looking at the teeth and considering the teeth every time. But that's going to take a long time because most of us weren't trained to do that. And so reversing the paradigm is going to be a slow process, but that's why we've been doing this. And so there are some key symptoms that should clue you in. Number one, 90 to 95% of these cases are going to present unilaterally. Unilateral, okay? Most sinusitis is going to be bilateral, okay? So no, we don't know exactly how common ODS is compared to all types of sinusitis. People love to quote 5%, 10%, 12%, 20%. It's going to be a while before we can get there because we don't have an ICD code for it yet. People aren't keeping track of this stuff. But what we have been keeping track of in a pretty nice manner is amongst unilateral conditions, it's the most common cause. Unilateral maxillary sinusitis, the most common cause is odontogenic sinusitis. So if you have somebody presenting with unilateral symptoms, frankly, we're not the best as ENTs asking about sidedness of symptoms. I've looked at a lot of partners' notes, my own notes early on. A lot of people say congestion, postnasal drip, pressure. Where was it? Okay. So first off, ask about, oh yeah, so you have this colored mucus that you're complaining of. Is it on one side? I mean, it's a powerful question. The number of times the patient answers me, oh, you know what? It's actually on the left. I'm like, ding, ding, ding. And I'm not saying it's always going to be ODS, but it's amazing what you end up finding if you start asking that question. Okay, so sidedness, because it's usually unilateral, colored thick mucus, and foul smell. Okay, these are the two most common symptoms of ODS. 2 prospective studies have shown that, one by our group, one by Dr. Simuntis out of Lithuania. I mean, it's pretty convincing. Foul smell is significantly more common in ODS than non-odontogenic rhinosinusitis. And so if you can tease those symptoms out, people love their pain and pressure. But guess what? We all know this. It's a very unreliable symptom in sinusitis. And to your point earlier, dental pain is extremely uncommon in these ODS patients. Why? Because if it's endodontic, it's usually a necrotic tooth. Or if they've had an extraction, there's no tooth to have pain. Okay, those are the 2 most common causes of ODS. All right, so to summarize there, getting a history of unilateral symptoms, seeing a CT scan that shows unilateral maxillary opacification, those 2 things together, you can really flip a coin. We have good data to support this. Flip a coin, 50% or more of the time, there's a dental source. Okay, so that's how you kind of get the tip off that it may have been ODS. Now you're in that treatment mode where you're like, okay, it's uncomplicated. We're not worried about spread to the eye or the brain, which I think we'll get to. What are we going to do first? Okay, so one thing we have based on evidence is that symptom burden can drive the decision, regardless of whether there's treatable or non-treatable dental pathology, which we will hit on because that's important. So the patient in front of you, they've got this foul-smelling, horrible pus pouring out their nose, going down their throat. Maybe they do have severe facial pressure, whatever. That symptom burden can drive you to tell them, listen, we can do upfront sinus surgery and get you feeling better, but if there's treatable dental pathology, they're going to need to treat it. I think we're not at a place, I know there are a couple studies out there suggesting that maybe treatable dental conditions won't cause sinusitis after you drain the sinusitis, okay? But I think we probably shouldn't promote that message just yet. We probably need longer term studies to support that. So for me, symptom burden, once I think it's ODS, symptom burden becomes the most important. But then you do have to coordinate both sides of the ball. They're going to need dental care. And hopefully we can keep getting this message out that dental specialists right now are the best at managing this condition. We may get to a place in the future where general dentists also, for instance, root canals of these teeth, extractions of these teeth, frankly, and then the oral surgical complications that they actually have a bone graft, dental implant. These are all pretty complex situations. And so you probably need to help coordinate, or at least this is what I do. I don't know, Dr. Sabene has a lot of dental colleagues in his area, so he has this too. But having networks with these dental providers, getting those patients to them would be my next step. If they are not that bothered, if there's like, yeah, you know, I get a little mucus, it's a little stuffy in my nose, I don't push those patients to sinus surgery because dental treatment can resolve these conditions. And we don't have perfect evidence yet which patients do or don't resolve by dental treatment alone. But if we just look at the extraction-related published data, roughly 50 to 60% or so of patients who get an extraction for their infectious ODS, not mucosal thickening, they're going to resolve. But there are, amongst those studies, one factor that seems to be coming out as a negative predictor for dental treatment is if they have spread to the ethmoid, sphenoid, or frontal. Okay, so extramaxillary infectious sinusitis spread, dental treatment alone may be a little less likely to be successful. I mean, The levels of evidence there are not high, but I think there's enough patience between all those studies to say there's probably some connection. All right. So to summarize there, it was if they're miserable, consider upfront sinus surgery. We've got a nice prospective cohort study to support that, but you always have to get the teeth treated. If they're not horribly miserable from this, get the dental treatment first, follow them back in about 2 months or so. We reached international consensus of somewhere between 1 to 3 months. If it doesn't resolve within that time frame, I just think it's kind of messed up that patients live with their ODS for, 6 months or more. But B, we don't want to miss, oh yeah, I didn't say this. I'm talking right now about if they got the dental treatment first, you got to follow them up to make sure the purulent sinusitis resolves, because 10 to 15% of ODS is asymptomatic. I mean, we're talking florid pus could be draining down someone's throat on endoscopy and they do not notice it. And what are those patients going to be at lifelong risk for? Extra sinus complications, orbit, brain, osseous. So in my mind, if they still have pus at that follow-up after primary dental treatment, I'm still advising them to have sinus surgery. This is not rhinosinusitis inflammation where if they're asymptomatic, live life and you're great. This is purulent, nasty sinusitis that can spread. So that was a long answer. I'm sorry.
That was a great answer. Alberto, did you have something to add to that?
I wanted to follow up on what John said. I perfectly agree with him. And I just wanted to point out that this study he's done on whether deciding to have upfront endoscopic sinus surgery or dental treatment to patient is the one study that made me fall in love with his work. Because I discovered, I said, oh my God, this man understood everything. And this is what we try to put in our OCNA issue. So there's science here. And it's just not saying, okay, in my last 10 years of practice, I did this and done that. No, I'm thinking about what we can do to get things better for this patient who, as John usually says, are miserable usually.
So, we talked about these people whose dental pathology de novo, for example, is causing their ODS. What about more iatrogenic problems, Alberto? What if they've had bone grafts or dental implants and now they have ODS? And I'll tell you, not only are they miserable in the United States, but they've also shelled out a lot of money for their oral surgery. And they've paid, oh my goodness, the cost of a car sometimes for all of these implants. And now, one of us is saying, oh, too bad, it's causing an infection, gotta go. So Alberto, what do you think? What's the correct management of these patients with implants or surgery previously that seems to be the cause of their ODS?
This is a wonderful question because we got one easy answer, which is usually the staple of anyone who wants to somehow diminish ODS. And so they just say, take out the implant, take out the augmentation, take out the diseased tooth, and call it a day. Most probably the patient will get better, but we are not aiming at the patient in this way. We are aiming just at the disease and as a simple resolution. We have to acknowledge somehow that the teeth or the implants or every dental work is a limited and precious resource and investment for the patient. So removing it is more often than not a suboptimal choice. Collaboration is once again the key. Starting from non-surgical complication, there's the article in the OCNA issues by Bangkok and colleagues about endodontics, but this can also be somehow expanded to all the iatrogenic complication. We have to try to, first of all, decide whether or not go to upfront ESS, but also decide which will be the extent of the oral surgery revision. So if we are able to understand exactly what is happening, so for example, when it comes down to implants, we have to ask several questions. So is the implant stable? So it is not moving when I just check it with my bare hands. So this implant might be saved. So I have to check the peri-implant osteitis infectious process, its extent, and whether or not I can treat it conservatively without taking the implant out. So once again, a good collaboration, which I advise to keep with the surgeon who positioned the implant, because that surgeon will be your most powerful ally in treating the patient, because he's the first one not to want to remove something that he has done. So if you can just keep the implant, it's a very, very good idea. You have to bear a really good relationship with the patient. So you can say to the patient, I'm looking at your sinus from the inside when I'm doing surgery, and I will check whether the implant is exposed inside the maxillary sinus or not. If the implant will be exposed, I might decide to take it out. You're okay with it? Or just leave the implant there if you want to, knowing that there will be an unknown chance of your sinusitis relapsing. Is it okay for you? Okay, we can manage it together, me, you, and your dentist. It's a little bit more easy in my experience when it comes down to maxillary sinus augmentation, because in that cases, radiology gives us a little bit more of information that we can use. So if you look at an augmented sinus, you usually have two options. You get all the graft in the bottom portion of the maxillary sinus, which has some kind of integration. So most cases, when you have an integrated graft, the patient will do very well with just endoscopic sinus surgery, and that's all. If you have some degree of graft floating free inside the maxillary sinus, most probably that graft got infected in the first place and then spread the infection to the whole maxillary sinus. And in that cases, most probably the patient will have to remove the whole graft to warrant resolution of the infectious process. As John pointed out, we don't have prospective information for these patients. So I can tell you that in my practice, we tend to remove the infected graft together with endoscopic sinus surgery in the same surgical setting, and patients are doing really, really good. But we exactly don't know if these patients do require such a huge extent of surgery. So once again, less is better in my opinion. And always think of endoscopic sinus surgery first to relieve patients from these symptoms.
Just on a sidebar, is there any role for hyperbaric oxygen to try to salvage any of these augmentation or implant, anything like that?
Not that I'm aware of, and maybe it could work, but I expect that hyperbaric oxygen, so enhanced oxygen pressure, wouldn't reach the inside of the sinus. So even if we take into account that somehow it reaches the infected bone where the vessels still are, the oxygen wouldn't reach the inside of a truly infected maxillary sinus, which usually has a greater pressure than the external environment. So I don't expect it to be very, very successful.
John?
I would first state that Dr. Sabene's group probably has higher volume than most places when it comes to oral surgical complications. So they have an amazing experience with this condition. But his point is very well taken at the end that this is an area that would be fruitful for research. So anyone out there that works with oral surgeons or oral surgeons themselves, this wouldn't be hard to study. Okay, but there are some big hangups here. Once again, we get back to the problem of using imaging alone to detect whether something's infected doesn't do the trick. And then the physical exam, it's helpful in the fact that if an implant is stable, that implies osseointegration, but there's just a lot more going on, and I don't pretend to understand all the nuances, but I can tell you this, clinically, it's extremely rare that my patients with what look like infected bone grafts need them removed. So we need to figure out, like, which of these patients actually need their grafts removed, because it's a major process. It was a decent amount of time and money on their part to get it done. They wait sometimes 6 months or more before they can get the implant. And then, God forbid, it might be infected. They go through this process of numerous appointments, poking and prodding in there. It's very unclear to me what's being done. And now, having talked to a number of oral surgeons, it is not straightforward determining whether these bone grafts and implants are always infected. So I think we do play, for now, until better evidence, we play the primary role, in my opinion, draining the sinus. Okay, antibiotics we'll probably get to. They don't usually work, but draining it, it's amazing how few sinusitis recur after that situation. So that's the last clinical point that I think ENT should be aware of. You drain that sinus, the patient's following with their oral surgeon or whoever did the graft and the implant. What's next? We just have to monitor for sinusitis recurrence. I think that would be a pretty good sign that whatever's going on below the sinus is still a problem. And then the last thing, he mentioned implants, whether they are or not exposed in the sinus. Not a great study yet out there showing the frequency with which it is. The majority of implant-related sinusitis cases I've taken to the OR don't have implants exposed along the maxillary sinus floor. However, I just did one recently, and there was a lot of exposure. And once that implant is exposed, they have pretty good evidence about biofilm formation on the threads of these implants and the recalcitrant nature of these infections. I think for now we can extrapolate from that, and an exposed implant probably is going to be an ongoing problem. But if the patient's like, listen, I don't want it removed. Well, we deal with facial trauma all the time, and they have plates and screws exposed in their sinuses, and some of them don't get infected. And then some of them just don't want to get them removed. So I guess my point is, have that rapport with yourself and the dental surgeon. And if you have the true team rapport like in place, these go a lot smoother.
So, I started this podcast by pointing out how patient-centric Alberto and John had made this issue of otolaryngologic clinics of North America. And I think that the whole discussion really centers on the patient as opposed to a tooth or an apex of a tooth or a sinus or a complication.
Yep.
And I think those are really vital points to keep in mind. And I think we talked a bit about research that is due. So if you're listening and you're interested, both of these gentlemen are very accessible and would be great to work with. And I think if you have some good research ideas, I think they'd be happy to bounce them off, help you bounce them off of them and get some projects underway. We're coming to the conclusion of this wonderful hour. I want to thank you both. And before we sign off, maybe share, I know you've dropped a lot of pearls here. We almost have a full necklace of pearls strung already. Maybe you can add a couple more. I'll start with you, Dr. Saibene. Alberto, what do you think? What do you think are a couple of take-home points that you'd like our listeners, dentists, otolaryngologists, students, other types of healthcare practitioners, what would you like us to remember?
Thank you, Susanna. The first one, it came up several times during our talk, but is don't just be an otolaryngologist or a rhinologist when it comes down to ODS. Think like a dentist and be careful as a patient would be. The second tip is get used to different radiology modalities. The more you can get for any radiology modalities, from plain films, apical radiographs to CBCT, the best will be for your patient. And the last thing is try to be careful for what's not there. John hinted before, extraction is the most common, maybe the most common cause of complication inside the sinus. So you just don't have to look at the teeth or the implants, the augmentation that are there, but think about the history and check for what you're not seeing.
Beautiful. John, Dr. Craig?
So I have another hour here. All right, I'll boil it down to a few points. But first off, ODS is not rhinosinusitis. We need to stop talking about it as another form of chronic rhinosinusitis. It does usually present chronically, and there is sinusitis. But let's stop calling it that, because we're not thinking about the dental causes. We're not thinking about the multidisciplinary needs of these patients. So I really think as a field, we need to start doing this. And the way we do that is we're going to keep peppering the literature. We've got a ton of studies coming out in 2025, 2026, but I anticipate a lot more after that because there's so much more to study. And then hopefully we get that place in sinusitis and dental guidelines. I think once we get into the guidelines reliably and we get different societies to take it up and maybe cross collaborate. I'm trying to work on some collaborations between different dental societies and the ARS, for instance. Then we start building that bridge, I think. Okay, so it's not rhinosinusitis. Another thing, diagnosing this, okay, it's not all about the CT. Okay, the CT is complementary. We as ENTs need to rely more on our scopes. The scope tells the bigger picture. If you just operate on everybody with mucosal thickening, guess what? They probably won't have complications. They might feel something different. You might think you fixed their sinusitis, but that's not true. And then so scope, most important for sinusitis. On the dental side, once again, the CT doesn't tell the whole story. You need to do an appropriate dental examination. And if there's endodontic disease, that's pulp testing plus periapical imaging. And so from an ENT perspective, I know it's painful and I know that you don't get trained to do this, but it's extra learning on your part. You need to know that when the patient comes back and says, nope, my teeth are fine, I saw my dentist, and that's our fault. Okay, we sent them to a dentist. I asked so many colleagues, who'd you send your patient to? I just told them to find their dentist. That is not helping the patient. I'm sorry. I've seen, and there's an older study that shows the false negative rate was extremely high from a general dentist practice. So again, we need to know how to diagnose the condition properly. Maxillary sinus mucosal thickening on a CT is not usually odontogenic sinusitis unless there's purulence when you scope them. But it's still a sign that there could be dental disease. We got to detect that and treat it. And then my last point just is always, we need to keep collaborating. We've talked about it endless times in talks on this podcast throughout the issue. We don't know about the teeth and they don't know about the sinuses. None of us know about the scans or the nuances of the scans. Very few of us know about the organisms that actually cause this condition. If it affects the eye, guess what? I barely know anything about how the retina gets affected by, and then subdural empyemas and the effects of those. Again, my point is a lot of different doctors have to be involved in these patients' care. And we're just going to keep at it. So thank you so much for having us.
Well, thank you both. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today, I've had the great pleasure of speaking with Dr. John Craig and Dr. Alberto Saibene, who are the guest editors of the December 2024 issue of Clinics, which is on odontogenic sinusitis. What I haven't mentioned until this point is that I actually got to know Dr. Craig on social media because he is really great at doing continuing medical education about oddities, especially about ODS on social media. And then his former chair and my friend, Dr. Kathy Aramchuk, introduced us at a meeting. And then we bonded over our mutual love of rap music. So you never quite know
Yes.
when you'll find a friend in various aspects of your life. You can find John at John Craig Nose, Nose. Very clever, John. So JohnCraignose on X, and on his YouTube channel as John Craig, rhinology skull-base surgery. And you can find Alberto Saibene at ENT_AMS for Alberto Maria Saibene.
Yeah.
And at Alberto Maria Saibene on LinkedIn. Dr. Craig is division head, rhinology, and clinical professor in the Department of Otolaryngology, Head and Neck Surgery at Henry Ford Health, Michigan State University College of Human Medicine in Detroit, Michigan, USA. I might also say Detroit, Michigan, USA. Dr. Alberto Saibene is Associate Professor of Otolaryngology Unit in Santi Paolo e Carlo Hospital in the Department of Health Sciences at the University of Milano, which is Università degli Studi di Milano in Milan, Italy. And they may have a lot of dental disease there, but they have a lot of fashion there. So the next time I go, Alberto, I might pop in and just say hello.
I'm looking forward for your
I would love it. You can find all the podcasts and all the issues of Otolaryngologic Clinics of North America at www.oto.theclinics.com or in your institutional or hopefully personal libraries. And the podcasts are wherever you get your podcasts. Please do share this information with your colleagues, both in otolaryngology and in dentistry and across specialties and with your trainees. And please go ahead and send me any feedback that you have, because we're always trying to make things better and more available. And unlike the Eminem lyric, next time there will be a next time. And I really look forward to the future of better patient care for people with odontogenic sinusitis. So thank you so much, Alberto Saibene and John Craig, for spending this time with me.
Thanks so much,
you.
Jana.
Thank you. It's been a pleasure.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, focusing on odontogenic sinusitis, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our 60 other titles spanning all medical disciplines, visit info.theclinics.com. Please be sure to follow us on Twitter and subscribe to the Clinics podcast wherever you get your podcasts.